Well, hello everybody, and welcome to AO North America Hand Education Committee weekly Hand Internet live series. And we are, I'm Marco Rizzo. I'm one of the members of the Hand Education Committee and one of the hand surgeons here at the Mayo Clinic. So tonight's session involves a discussion on acute boutonniere and how to operate on the High 2 series. And also Dr. Sincere from Scott and White, Baylor, Texas A&M is going to speak on the Venkataswami Flap and its variations. I will preface to say that we haven't seen Michael yet, so hopefully he'll be on board in the latter part of this session, and we'll keep you posted. Okay. This is again the disclosures from all of our faculty and staff, and thank you all for being here and participating. Zoom etiquette: all of your microphones should be turned off and muted, and the video is turned off. Send questions to the Q&A box on the Zoom screen. Tonight's moderators are Dr. Mazzara and Dr. Gupta, and they'll review questions as they appear and present them to the faculty. Use the Q&A for questions related to the discussion topics that we're reviewing tonight. We do have upcoming must-know series. One next week is on tendon ruptures about the wrist. July 16th, we'll be discussing tendon transfers for radial nerve palsy. The videos next week will be for ulnar artery perforator flaps, and the video for July 16th will be how to do a good split thickness skin graft. Finally, our last session will be how to get ready for life after fellowship. You can access all the previous recordings and tonight's through YouTube, AO Hand North America. And the link will be sent out through the Zoom 24 hours after the conclusion of this webinar to all those who have registered. Thank you again. Our charge tonight is to talk a little bit about acute boutonniere injuries. And again, I'm Marco Rizzo from the Mayo Clinic. I have no relevant conflicts related to this presentation. So I wanted to start with a case presentation just to get us thinking about this. And this is a 20-year-old male who is right-hand dominant and injured himself playing basketball through an axial load injury. He was initially seen, and then this is his presentation in a somewhat acute fashion. He's about 2 weeks out from his injury at this time. And he notes that he's been having this progressive appearance of flexion at the PIP and hyperextension at the DIP joint. So the diagnosis here would be an acute boutonniere, and how we treat it we'll discuss, and we'll get back to that case at the end of the presentation. So boutonniere deformities, these are very problematic, and the acute boutonniere, however, is something that really we have to have a heightened sense of awareness of, because we don't want it to develop to something like this picture shown here on the right. We'll review the anatomy and the pathoanatomy. We'll discuss treatment options for the acutes, and very thankfully we won't be touching much upon the chronic ones at this time. And we do see these sometimes more chronically in the rheumatoid patients, but this is beyond the scope of today's presentation. These are wonderful pictures from Dr. Gupta that from his book on anatomy, looking at the anatomy of the fingers, and there's a real wonderful delicate balance between the intrinsics and extrinsics in these hands. You can see the lateral bands coming across. These there's some nice pictures of the conjoined lateral bands coming all the way out to the DIP joint, and the triangular ligament seating right here past the terminal extensor. The central slip inserts into the dorsal base of the middle phalanx, and this is effectively what's disrupted when we have an acute boutonniere injury. This is a case of a chronic boutonniere, and you can appreciate what ends up happening and how the lateral bands slide volarly when the central slip has been disrupted. And this is effectively the genesis of the problem. When the central slip is disrupted, the lateral bands will slide volarly, effectively elongating the triangular ligament, creating a contracture volarly as well, and ultimately increasing the tension on the conjoined lateral band to develop the compensatory DIP hyperextension. So again, the treatment goals in the acute setting oftentimes are prevention, and a heightened awareness, as I mentioned, is the key. You don't want it to progress to this. So ultimately, having a heightened understanding and awareness of when to consider this and how to diagnose it is really critical for these many of these acute boutonniere injuries. By way of physical exam, again, oftentimes in the acute setting, they're not obvious. And there are some provocative tests that we can do. You know, a lot of these patients will have swelling in the PIP joint, they'll have limited motion. And the Elson's test I find to be a really helpful tool in determining whether there is in fact a disruption of the central slip. So how do we do the Elson's test? Well, the Elson's test is pretty straightforward. You actually will ask the patient to flex their finger at 90 degrees or hold it as shown here from his article. And when you do that, the actual DIP joint is sort of floppy in someone who has an intact central slip. You ask him to actively extend, and then if you assess the DIP in that setting, it should stay floppy. And someone who has an incompetent central slip, they will be very tense when they're asked to extend. And that will cause loss of that floppiness at the DIP joint. And this is a nice schematic that Dr. Dutton helped with a textbook chapter we wrote that illustrates the positive Elson's test in the picture below. And these photos illustrate it as well. Another important thing to do is to test active and passive motion, because you want to be able to make sure that they're supple. And that's a critical thing when you're trying to assess more chronic boutonnieres, but it's also very important in the acute setting. So here's a case example of an 18-year-old male who sustained an axial load injury. And you can see on the lateral x-ray that he has a little bit of a fracture fragment here, which is concerning. And these are photos of him at the time of the injury. So he has a base of the middle phalanx effulgent fracture. And let me ask some of our panel, Harry, what would you do for this injury? Let me show it to you again. How would you recommend or advise this patient to be treated?
Okay, can you go back to the x-ray there?
Can you see it okay?
Yeah, I'm gonna blow it up a little bit. You know, I think this is the key to this. Can you hear me?
Yeah, I can hear you.
Yeah. The key to this is, as you said before, is early diagnosis. Okay, these often get neglected as a sprain, missed, little rim avulsion fracture or something along those lines. So for this one, axial load injury, this is a PIP splint for me with an examination in 5 to 7 days and another X-ray to make sure that this is not going to lead to some of this imbalance.
Absolutely. Thanks, Harry. Yeah, so these two are the things that I use. I use these stack splints, which I don't have any. It doesn't matter. Sometimes you can have therapy make a splint for them custom. That's if they're between sizes, and some tape. And with these two instruments, you can actually fit them for a splint that holds their PIP extended and allows for DIP flexion. And this is him after, the x-rays are 6 weeks after the injury, but the video is 10 weeks post-injury. And this is not an unusual range of motion for someone after starting motion for 4 weeks. They're not quite at full motion at this point, but the keys in this patient to me are that he doesn't have hyperextension at the PIP, at the DIP, and he doesn't have that boutonniere appearance. He has a stiff PIP, which is a common thing that we treat, but this is, in my opinion, a successful treatment for him. I don't know if Becky is on the line. Hey, Becky, what are your thoughts from a therapy perspective here? How did I do? Should I have done something better at 10 weeks post-injury, or should I have started moving him sooner? What do you think?
Well, no, actually, I would say the true zero is always the biggest concern that we have when we put these people in the splint, right? And I think edema at the PIP joint can mask the true zero. So if you have access, if you have, or if the therapist has an access to your C-arm and can really put that digit under the C-arm to double check the true zero. And then for me, it's really about education. Love the tape. I think the tape is a fabulous idea because these splints slip so easily. So tape is such an effective way to treat them. I like a clamshell. I think it's nice to have the pressure from both top and bottom with the tape as well. And then that DIP range of motion. So really trying to maintain the length of the oblique retinacular ligament, maintain the good DIP flexibility. And like you said, I think 6 week post-op is, or 6 weeks later is when you really want to look to see how they're doing. And that PIP stiffness should resolve itself over time.
Thanks, Becky. We'll come back to you in a little bit as we get more interesting here. And again, as Becky alluded to, I think there's different types of ways of making splints. Some of these are really archaic, and I wouldn't recommend this cast per se. I like this stack splint. Some people reverse a ring splint to function like a stack splint. In this case, I like encouraging DIP motion, as Becky mentioned as well. But remember, the PIP is an unforgiving joint, so it's not unexpected that you'll have stiffness even when you have a successful radiographic outcome. Now, the charge of this talk is when do we consider surgery? So let's get into the meat of it. As many of these as can be treated non-operatively, there are some that require operative treatment, not just the ones that fail non-operative treatment. And typically, I would consider failed non-operative treatment at about 2 to 3 months. I wouldn't wait too long on these until so that they develop that more fixed deformity or worsening of that boutonniere, because rebalancing that intrinsic-extrinsic balance is a real hard thing for us to do as surgeons, and keeping it is the key, and avoiding it from getting severe is the key to success. But if you have a boutonniere with a fracture, a bigger fracture like the one we showed in the first case, I think that's an indication for considering surgery, particularly in patients who have subluxation of the joint associated with the fracture or large fragment. People who have volar dislocation subluxations, those are, I think, often associated with a central slip injury, and the actual time to consider surgery, I think, is more debatable. But I tend to favor having a heightened awareness for that central slip injury, and if there's an associated fracture fragment, considering repairing that. And finally, I think open injuries where there's a laceration, I think it's an obvious indication for considering a surgery, at least, especially if it's a contaminated wound or if there's associated other fractures with it. Dr. Peter Stern, published a guideline for us on how to handle some of the fractured ones. And if it's over 50% and or displaced, in addition to patients with subluxation, then the recommendation was to consider surgery in those patients. So here's another case example, a 34-year-old right-hand dominant who had this injury associated with the PIP joint. Let's see, Kevin, what are your thoughts here? How would you manage, or what are your concerns?
Well, I think, Marco, if you really look critically at the lateral x-ray on the right, there is some degree of volar subluxation of that PIP joint, that sort of V sign dorsally there as well. And so here you have imbalance between the basically incompetent extensor insertion onto the PI or base of the middle phalanx, and then the intact FDS, which is going to be pulling it in that volar direction. There is, on the image on the left, it looks like there's a fragment over on the radial border of the proximal phalanx head. Unsure where the origin of that fragment is from, but suspect that it's also likely from the base of the middle phalanx, as it looks like there's a pretty sizable defect there. So, given this degree of joint instability, the displacement of the fracture fragment, and again, the image that's on the left there with that fragment, really farly displaced from the PIP joint or the base of the middle phalanx. I think this one for me would require surgical intervention and likely with an open exploration and reduction.
I agree wholeheartedly. There's two fragments here. There's this lateral fragment, which actually, you know, a spoiler alert, this is actually articular surface from the PIP, from the base of the middle phalanx. And then there's this other dorsal fragment, which you can see here. And this is a nasty injury. And I did, as you suggested, you know, the joint is sublux, like we talked, like you mentioned nicely. And with this subluxation, I felt, in addition to that, that dorsal fragment, there was that radial fragment that you mentioned as well. So some would recommend a CT scan in this setting. And as I had a heightened suspicion that I would be going in surgically and opening, I felt that it wasn't absolutely necessary in this patient. This was an illustration of fluoro images in the ER showing the stability or lack of stability of the joint when you're positioning it. So we've diagnosed it pretty well. Jeff, how would you talk me through or talk a resident through how to treat this? What do you think from a surgical perspective?
Yeah, so I think you mentioned opening it up. I agree with you. A CT doesn't add a whole lot, but you know, you want an approach that's going to let you see that dorsal fragment and then that sort of base, that radial base fracture. So I would go probably adjacent to the central slip, between the conjoint lateral tendon and the central slip, and then reduce it. And obviously the sort of the A game is to put a 1.0 or 1.2 millimeter screw in that fragment. But the most important thing is to get the articular surface reduced. And if you have to use threaded K-wires as a second best, I think I would probably do that.
Well, that's great. You know, and I know I've seen Jeff's work and he does wonderful work as ORIF stuff. I mean, I was hoping to do that. The fragments themselves weren't as big as I'd like them to have been. So I opted to go with a fallback with just smooth K-wires after reducing the fragments into place. And this was his position after securing the central slip. I also used sutures. I regret that I don't have some operative photos. But this is the reduction, and because of the tenuousness of these fragments and the repair, I opted to pin across the PIP joint. You know, let me say, Jay, was that a good idea, do you think? I mean, do you do this? Do you pin across the PIP joint?
I try not to as a rule. I try not to pin across the PIP joint, although that what you described is a great principle. You have to have a fallback plan. I'd rather have a joint that's reduced that we can address the stiffness later. But in this setting, when you're trying to protect those small articular fragments, some provisional pinning, it's probably, how long did you keep your pin? Maybe 3 weeks, 4 weeks?
It was about 4 weeks, yeah.
Yeah, so I think in that setting, when you're taking it out at 3-4 weeks, you're gonna have some stiffness, but you can probably gain that back after you regain some early healing from those articular fragments. But I agree with you, you gotta have some type of fixation that keeps your joint aligned. That's key.
Yeah, I don't like to do it either, Jay.
Marco, but even, you know, to play devil's advocate, even if it got so stiff and you needed to do a capsulectomy, you know, if the joint is anatomic, you're still way ahead. You know, if you pull out the pins too early or go for too early a motion, you know, then you got nothing. You know, then you got no articular reduction and you can't hope to get motion. So I think this way, at least you got the anatomy normal, and you can always take them back. I mean, obviously you don't want to take someone back to the OR, but you can always take them back and do a capsulectomy.
That's a good point. Good point, Jeff. Any other
Jay, Marco, just one quick question on the, and Jeff, I think you alluded to sometimes the screws are so tempting, right? Because it's this piece, you have direct access, it's straightforward to put it in, and maybe give the audience a little bit of the gauge of, I'm always leery that it's, you know, the force of the intrinsics and the collateral and everything is going to pull out that as the joint subluxates. If the joint's not subluxated at the beginning, I'm more inclined to have a screw, but I get very concerned because it's a fracture dislocation, and dislocation has so much force in these situations.
That's a good point here. A good point. Any other
I
comments?
almost want to see a bigger piece. The bigger the piece, the better.
Yeah.
Yeah, Marco,
Yeah, Tom.
I think pinning the joint is perfect. I mean, I think one of the mistakes I tend to see is when people don't pin a joint, whether it's a DIP joint or a PIP joint, trying to hold small fractures, whether it's a mallet fracture distally or something like you're dealing with here. I agree completely with Jeff. I think, your goal is to restore anatomy. Obviously, you'd like to do that and maintain full motion, but sometimes you have to take at a step at a time. And if you allow motion too early, your reduction is lost.
Thanks, Tom. So this is him. I think this was the 4-week period where I was about to pull the pins, and this is him at 3 months. So Becky, how can I get better extension here? Is there something I can do for this patient?
Yeah,
Other than I gave him Dupuytren's disease from the trauma probably too.
So unfortunately, I'd love to put my hands on this patient and see what I could manipulate to see if I created some Mcp Flexion, if we could get any extension pushing through that extensor mechanism, if we feel like we have some scarring going on versus actually a joint contracture that's not allowing that full extension. So I would want to assess both volarly and dorsally to try to understand where this issue is arising from, and then try to address it from there. Sometimes in these cases, if you put them in almost like an ulnar nerve splint, so put that MP into flexion and try to really translate forces through the extensor digitorum, sometimes you can help with this, but I would love to put my hands on this to feel it, to understand where the problem is coming from. Can you give me any insight on that?
Well, he had a pretty firm active equal passive extension kind of thing. So my thought was that it was more of a joint contracture issue. And I gave him an LMB splint. I like the LMBs, and once they're healed enough, I think at 3 months, or even earlier than that, you can get pretty medieval with them, and it did help. It actually got him a better extension. I was delighted that he had good flexion, I think, and I welcome your thoughts. Lack of extension is more common, but lack of flexion is harder to make better in my experience. Has that been your experience or no? Or they both are hard to make better?
Yeah, when I think about the PIP joint, I think about a joint that's closed packed in extension. And so what I know about that is my ligaments are lengthened and the joint spaces are minimized. And so I would rather immobilize an extension and deal with those things later. I do think it's a little bit more difficult. I don't know. It's a good question. I think it depends on the structures. Trying to regain that extension can be incredibly difficult. And like you said, the flexion, we have all kinds of splints and contraptions to make it better. An LMB is a great choice. If you have a therapist who's really agile with biomechanical angles and can create a good dynamic splint at the PIP joint, that's a hard thing to do. It's not as easy as it sounds, because that 90-degree angle of pull, you don't have as much length of the splint to actually make that happen. So I think both are pretty challenging. The PIP joint to me is the hardest joint to treat in the whole upper extremity.
No doubt. And, I've had, I'm trying to, the flexors are obviously stronger than the extensors. So I can see why lack of extension is often more common. But I very rarely do I get full extension in these cases. Very rarely, very rarely. Any other comments from the faculty? Amit, what do you recommend? What do you think, Bob?
Yeah, these are always very difficult, but I think, as you said, that I agree with Tom and Jeff that I tend to pin these and try to get extension more than anything else. And if you get some stiffness, you can always deal with it. But I think pinning is for me to try and get that extension or keep that extension is very important. So the timing of the surgery and get that finger PIP joint extended is the key points.
Thanks,
Marco?
Ben. Yes, Tom.
Is it possible the Dupuytren's disease could be playing into your contracture?
It can. I didn't think it was the case in this patient, but you know, oftentimes when you see that we see post-traumatic palmar fascia, as Peter Stern wrote about this, it can technically, yes, but I don't think that maybe in 10 or 15 years it'll be a problem, but there wasn't a really significant palpable obvious tether from that, but that could certainly be the case in some of these patients.
Hey, Marco, this is question. How often do you have to plan a second stage PIP joints and these particular cases, especially the ones that are a little bit more complex? Is that a common thing that you kind of counsel the patient for, or is that an unusual situation?
It's a common thing I mentioned, but it's something that I really have to go into sort of kicking and screaming. I really want to exhaust all the therapy options before even considering it. First of all, you want to be sure you have a patient who's the right patient for that, and you got to have all your ducks in a row if you're going to proceed. And it would have to be a pretty compelling argument to either the patient needs to convince me that they need that extra motion, and because it's timing, you know, it's a hard thing to actually improve upon. And sometimes we frankly fail, even though we get our ducks in a row. For example, we would plan a wide awake surgery because you want to be sure that it's not tendon adhesions. You want to make sure the tendons are healed. So you want to do it at the very earliest, no earlier than 3 months from the surgery, to be sure that the tendons are completely healed. And afterwards, you want to be able to sort of start therapy either that same day or the next day. Plan volar and dorsal approaches, do it while they're wide awake so that you can be sure that you can have an active patient participating, because passive, and you want to be able to make sure it's just not a passive problem. You want to be sure that they can actively correct as well as passively. And together with the right patient, you can get a home run sometimes. And obviously, the more severe their contracture, the more they have to gain. Sometimes I'll see patients who have, 20 degrees short of total arc of motion, and they're asking if there's something surgical we can do. Well, trying to get that little extra bit better is a tall order. It's the ones with the more severe contractures who have the right spirit and right build to put up with it, because on paper it sounds great, but in reality, they're going to wake up the day after, once the block wears off or the numbing wears off, they're going to be painful. They're going to be swollen. They have wounds now. They have to sort of tend to those, and they're going to have drainage. So once those factors start to build up, the patients can get easily discouraged. They can become frustrated. They spiral out of control. And then Becky has her hands full trying to keep these patients going through the whole process. And it's very important that you have the right patient, and you have the right goals and expectations, and you have the right therapist to be there with you to partner with it. Becky?
Right.
Dr. Rizzo, I'd add the other piece for me that is always interesting about these is I think there's this really fine line between waiting too long and starting too soon, right? There's that moment. And the two things that I often remind people, one is that we've got options for short arc motion. So motion isn't all or nothing. We can progress motion in small amounts and teach the patients to do that pretty easily. The second is that I think therapists and patients alike both focus on flexion and don't really put enough attention towards that full active extension that we know that we really need to maintain the full extension. So I think those two things for me always come to mind on these as well. And even, post-capsulotomy, but post-tenolysis, whether it be volar or dorsal, that full extension and full flexion, making sure that we have that equal and opposite reaction happening, I think is really important to consider.
Thank you, Becky. Those are all great points. A great question, Kim, and we wrestle with it routinely, and it is important that every patient know, but it's something that I've been very judicious about when we pull the trigger on.
Right.
Another big deal. It's made a big, since wide awake surgery has become popular, it's made a big difference in the outcomes in these patients, in my experience, when you do these releases.
Yeah, I agree. It's great. Another question that came up was, do you see a different outcome between the bony and the soft tissue injuries? Is one perhaps a little bit more forgiving than the other, or do they both kind of end up the same way in your experience? And just kind of wondering what the outcomes are.
Comments from faculty too, but I think I agree with Harry. Bigger bony pieces are more reassuring to me. I think the small bony fragments are tough because they're the worst, because they invite more instability, and they're effectively like a soft tissue problem with a more tendency for instability because you've lost some of the bony constraints of the joint. The strictly soft tissue ones, most of those I think can be treated with, if you get them early enough, conservatively. So it's the small bony fleck fracture fragments like this, the one X-ray we're just looking at here, that I think are the more challenging ones to really predictably make better. I wonder if anyone else would agree. Okay.
Yeah,
Well,
no, I think you're exactly right. I think in my hands, I think those, when you see these small, like this one you're showing here, those are the ones that you kind of just go, oh no, because you know it's going to be a bit of a challenge as far as the functional outcome.
The nice thing about these injuries is they give you the clues that something bad is going on, and those are helpful because sometimes something bad's going on and you don't have, like this is a patient, and this leads into the next case. It's a 38-year-old who had a dislocation, you know, and many of these dislocations, I suspect are treated without actual surgical intervention, but when they have a bony fleck fracture, there's this heightened awareness, and these volar dislocations, I would caution folks to be a little bit more concerned about, because the central slip avulsions are big concern in these, even without the fleck fractures in these patients. So reducing them and splinting them, many times we can get by, but in this case with the instability, it was a tough decision about what to do. And this is him after reduction. And let me ask you, I don't know, all right, Jay, sorry to pick on you again, but would you consider treating this non-operatively at this point since you got the reduction, or would you?
I don't feel that I can trust the reduction or to keep the joint reduced with that fragment, and there's still some displacement. An open approach to treat that, to do either through a small screw, if it's a large enough fragment, it looks so small, I might consider a suture anchor to grasp that fragment with the central slip. But I do think that an open technique, I would not use closed technique alone. I would do an open technique.
Yeah, so that's what I ended up doing. And you know, I'm disappointed that this bone fragment, but with the suture anchor, I was able to get it down nicely. It's funny how these bone fragments sometimes resorb. When you're looking right at them, they're right down, but they resorb. But despite that, this patient went on to do pretty well. Let me see if I can.
Can I ask you a question, Marco? Yeah. In your thought process in the OR, do you look at the joint after placing your anchor and pinning the fragment? And if the joint's aligned, would you go with a transarticular pin, or you look for other indications for or is it just always you get a transarticular pin?
No, I don't always do. I look at the joint and I get a sense of the stability. And you could argue that if you're not completely stable, you should make it stable. But in this case, it didn't feel quite as stable as I would have liked it to be. And I've gone away more from, I happened to pick two cases that were a little older here, but I've been going away more and more from the transarticular pin. But you know, that comment Jeff made and Amit made are very real.
Yes.
You'd rather have a stiff congruent joint than an unstable, sublux joint or a stiff sublux joint, because that's going to be very hard to make better. So, I would caution you, if you're early in your practice, I would have a low threshold for doing the transarticular pinning. And but I've actually moved more away from that, Jay, recently, and I
And
think
when do you start moving them? When do you start moving them if you don't place a pin? We talked about taking a pin out at 4 weeks. If they don't have a pin, would you slow down on their motion?
Well, you know, I would either splint them, but very likely if I'm not pinning, I'll probably start a short arc protocol at about 2 to 3 weeks. And Becky, I welcome your thoughts. Does that sound like, or even earlier, if when would you recommend starting if you're pretty happy with the stability?
If you're happy with the stability, what I want to do, the first thing I want to do is take really good measurements, and I want to take consistent measurements over time and let the data speak to us about how we want to progress. And so I would go with your 2 to 3 weeks suggestion, but I'm also, again, I'm watching that lag really, really closely, and I'm going to be measuring consistently and very, very often. The other thing I love with these injuries is to give the patient a lateral tracing of their digit that they can go home and try to make sure they maintain. So they're not measuring at home, but they're using a template to actually see if they're seeing any changes in the extension they're able to produce. And then base some of their decision making and calling me back to see if they're starting to lose any extension. The other piece of the puzzle is this is where telehealth is a really interesting opportunity, because if I can have my patient even just see them on their FaceTime or using more HIPAA compliant platform, obviously, but thinking about just looking at them and looking at their extension rather than having them come all the way into the office could be a really interesting and approachable use of a telehealth type of mechanism in these cases.
Well, thanks, Becky. And Jay, to your point, you know, I get them moving at the DIP right away, you know, yeah. So it's just the PIP that I would protect for those 2 to 3 weeks. You know, it's a constant sort of evolution, and I'm learning as I go with these in terms of when to be bolder, when to be a little bit more, but, you know, while I tend to think I'm a little bit overly conservative in general, I haven't gone to any situations where I end up with the stiff joints like I showed on the videos, but I haven't had some of those catastrophic subluxations that you know, are going to yield ultimately to post-traumatic arthritis or a really, really unfortunate situation with recurrent deformity.
Marco?
Yes, Tom.
Just a quick comment. You know, this to me is a more unstable dislocation fracture pattern than is, you know, typical for just a volar dislocation. It, to me, looks like a volar rotatory fracture dislocation. So it includes the collateral ligament likely, as well as the central slip. And this is one that I've treated a bunch of them closed in different kind of situations, but I think this is one that you probably made a good choice to pin and keep extended.
And that may explain why, you know, and I got that sense too, because it wasn't just a central slip injury, Tom. And I'd be curious in the professional athletes, Tom, do you treat them, how do you get them back to playing right away? Or what's the soonest you would recommend he go back to, or she go back to playing?
Well, it depends a lot on the athlete. I mean, my experience is primarily with football players, and I can tell you, I've done it both ways. I've treated people closed, not quite with that sort of central slip fracture, but more of a, you know, an avulsion type of injury together with the collateral ligament. I've treated them closed, splinted an extension if I had it fully reduced, and some players can tolerate that depending on their position. I've also played plenty of players with a pin across the joint with appropriate splints. So, you know, it just depends on the specifics of the sport, position, and the injury.
Thanks, Tom. Any other comments from faculty? So just in summary, these Boutonniere deformities can lead to significant dysfunction of the finger. It's a result of from the central slip disruption, there's an imbalance between the intrinsics and extrinsics. As I mentioned earlier, heightened awareness is essential for a good outcome in these patients. And prevention is the best treatment. Non-operative treatment is the mainstay for most of these injuries, I think, but it's important to know your surgical indications, and appropriate and early rehabilitation when feasible is essential to a good outcome. So let's go back to that patient from earlier, the 20-year-old, and this is what I ended up doing with him, and you can see his motion at 3 months. He has slight extension lag, a slight flexion lag, but overall went on to heal, has a nice, congruent joint. The beauty of this is when I don't see any hyperextension at the DIP, that's always reassuring to me in these cases. Thank you for your attention. Kim, any other comments or questions from?
Yeah, we have one other question. As far as going back to the diagnosis and kind of preoperative or pre-treatment planning, do you tend to rely solely upon physical exam and the Elson's test and x-ray, or do you think there's a role for additional investigations such as an MRI or a CT in this particular type of injury?
You know, we've gone to doing a ultrasound in some of these patients that are more subacute, or and their exam is more equivocal, and we don't really have a good Elson's test. I think the ultrasound, depending on your ultrasonographer, can be very helpful in confirming essential slip disruption. I think it's actually probably better than an MRI. It's a dynamic study, and you can sort of watch them move a little bit, and you can sort of see if the potential disruption. I'm not very savvy with the ultrasound, but thankfully here we have some very good ultrasonographers that can help.
Yeah, I mean, I think I've done the same here in Dallas and have used ultrasound quite a bit. I have kind of found a very good European trained ultrasonographer and who's very good at doing soft tissue and musculoskeletal sonography. So it's actually, I think you're right. I think it can be, in the right hands, it can be better than MRI. And it's the thing that I think I find with ultrasound is that it can be dynamic. And so that actually adds I think a very valuable piece to the study itself, is in the fact that you can do a dynamic study.
Absolutely, and I think it's only going to get better as people get more reps and more experience. That's a great question, though. I probably should have included more in the talk on that. Any other questions? Ahmed, is Michael here?
Oh, I'll do the talk. That's okay. I think I've got something here. So
thanks, Ahmed.
Okay, thanks, Marco. That was an excellent talk, and we learned a lot. Thanks very much. Thanks for your wonderful discussion. So my talk is going to be on the Venkataswami Flap and the modifications of the Venkataswami Flap. So I'll go ahead and share my screen. There you go. So we're going to talk about Venkataswami Flap and variations. Let us first see who Dr. Venkataswami is. Dr. Venkataswami is the founder of one of the world's biggest hand surgery units. It is in Chennai, in India, and it has a huge. It's a huge hand surgery unit with lots of residents and fellows, and I would say it's probably the world's largest hand surgery unit. So Dr. Venkataswami started that, and he is still a very active teacher there. So Dr. Venkataswami and Subramaniam in 1980 wrote an article in Plastic and Reconstructive Surgery Journal called talked about the oblique triangular flap. Basically, this is to cover defects of the pulps of the fingers. And this is Dr. Venkataswami on the right of Dr. Kleinert. So there's a very historic photograph of the two great pioneers of hand surgery, pioneer Dr. Venkataswami from India and Professor Kleinert. They're both my teachers. So this is Dr. Venkataswami's idea, was to take a flap based on one neurovascular bundle. This is like half a Moberg in a finger, because obviously in the digit you cannot do a full Moberg, unlike in the thumb, because the thumb has a good dorsal circulation. In the digit, you have only the two digital arteries, so you shouldn't do take both of them. So this is half a Moberg, taking the neurovascular flap and elevating it over the top. Now, over the this worked pretty well, but it was later found that what happens is that because it doesn't have any adhesions to shrink, it does tend to shrink back, and as it shrinks back down a little bit with scar contracture, it creates a defect in the tip of the finger and causes a little problem, not a defect, but a little prominence in the tip of the bone, etc. So there have been modifications to try and obviate that, to try and prevent this shrinkage. And one of the articles is by David Martin and David Evans, both from the United Kingdom. And this article was in the British Journal of Hand Surgery. And they modified it, and I'll show you the modifications of it, okay? So here's an oblique amputation of the tip of the finger. And the question is what to do about this. And we can look at this oblique amputation in the cadaver. And this is a modification of the Venkataswami Flap, where you can make zigzag incisions, and each of these zigzags will fit the one next to it. And therefore you take one neurovascular bundle. There's a slight point of caution that before you do this flap or decide to do this flap, you have to make sure that your digital arteries on both sides are working. So you do a digital Allen test and make sure that both digital arteries are working before you do this flap, because you're going to take one digital neurovascular bundle with this flap. So the finger is going to survive on the only on one digital neurovascular bundle. So then you take this flap and you elevate it to the level of the sheath of the flexor tendon. So you, just like you do with the Moberg flap, you elevate it to the sheath of the flexor tendons, take out all the interconnections of these small vessels and fibrous tissue, and go down all the way down to the palm almost to really open up the neurovascular bundle. And once you've done that, you can then flex the finger, and this will then cover the tip, and each of these small flaps will interdigitate, and this stops the flap from shrinking backwards. So here's a video of it. This was done by Michael Sincere.
Oh, you didn't start. Okay.
Ready?
So this is not non-edited video. So
we're going to describe the Venkataswami Flap, which is a neurovascular island flap. Here we've got a defect of the index finger, a Volar defect of the index finger. And the beauty of this flap is you're replacing like with like. So you're basically replacing this Volar digital defect with sensate, rugged tissue that can really take the resistance that the local tissue takes. So the design of the flap is in the following way. You'll basically draw a line along the mid-axis of the digit from joint to joint. And approximately here as well. And then the flap design can be done in a few ways. One thing to avoid is to avoid a straight line, because you'll get a contracture over time, and that's really not favorable. So we'll basically do just Bruner incisions. And this can be continued all the way into the palm as needed for additional length. But these triangular flaps allow you to interdigitate this flap and get less contracture than a straight line would. Martin Evans made a modification where they offer larger triangular flaps here. And the larger triangular flaps allow you to interdigitate even more and minimize the risk of contracture. So we'll start basically with a
Stills?
Yeah.
You want to erase any?
So
Back
finger.
up just a little bit.
Oh.
You didn't start.
Start. Okay, Venkataswami Flap. So we'll make our mid-axial lines here between the volar and the dorsal surfaces. And again, this incision here is basically ulnar to the radial digital nerve, so that we don't incorporate and destroy the innervation of the radial contribution of the radial nerve. So a little bit more ulnar on this side over here. So here, and I like to do small triangles.
So this is Dr. Sincere's modification, small triangles. The first one was the Martin Evans modification. I'll come back to that.
And this can be extended into the palm as needed.
So this is the basic drawing of the small flaps.
Because before you do this flap, you need to do an Allen's test, because if you're harvesting this flap on the ulnar digital artery and the radial is not working, that can be problematic. So just make sure you do an Allen's test to confirm that before surgery. And the other important thing is to if you can, save as many. The other reason that you don't want to sacrifice the dorsal branches on both sides is that you may compromise the blood supply to the dorsal skin. Unlike the thumb, there's no dual blood supply to the digits for the dorsal of the skin, so you want to be careful keeping as many dorsal branches. So what we'll do now is we'll start by making our incision. The radial pedicle is running basically right here, along the mid-axial line here, a little volar to it, so we'll preserve the radial sensory branches. And essentially we're cutting small triangles like this. Now under tension, we're just making a mid-axial incision here. Because before you do this flap.
So this is elevating the flap here.
And nerve here, right here. We want to confirm that that's incorporated into the flap, obviously. Now we'll essentially make the radial incision. And you can see also, you can identify the ulnar artery and vein to make sure that you're not incorporating that into your flap.
So the level is just superficial to the flexor sheath. You're not going to open the flexor sheath, and make sure that you take the ulnar neurovascular bundles along with the flap and leave the radial neurovascular bundles along with the digit.
Yeah. Right. We're good?
So you have to go to the palm.
Just a little bit here to get
dissect down to the palm.
Attachment release to get this advanced a little bit more. Again, keep the base really wide. Don't scalenize anything at all. And that way you can get a little bit more advancement. And so that'll cover 1 centimeter defect quite nicely as well. So we started off basically with this defect, and with a little bit of finger flexion, we can basically cover the defect this way.
Do you want to talk about MCP flexion versus PIP flexion? So I do.
This is a great flap because it allows you to replace like with like. You get instant 2-point discrimination after this flap. They get immediate sensation. It's really rugged. The most important thing I would say is that when you're splitting these patients, make sure that you're splitting the MCP, not just the PIP joint. You want to split the PIP joint as little as possible to avoid contracture of the PIP joint. It's going to get stiff first. So MCP flexion, when you're putting them basically in a splint, you want to make sure they're in a position of function, but you're flexing the MCP and a little bit of the PIP as well, so there's no tension on this flap. And then you see them back in a week to get them into a regular splint. And I get them into a nighttime splint for up to 6 weeks to work on their gradual extension, make sure there's no contraction. It's really, really important. So splint them, put the MCP down and the PIP as well, not just the PIP. You want to keep the PIP with the least amount of flexion to avoid contracture. The other important point is if the flap needs to be advanced a little bit more, you can also make a little zigzag incision in the palm and free up the pedicle just a little bit more in the palm. And that's going to allow you to release some of the additional soft tissue over the pedicle, which is right here. And this allows you to free it up as needed, get more advancement.
So this is the true Martin Evans, which is a bigger flaps. So each of the digital creases have a flap with it. So as you can see that this flap will close V to Y, and this will move here. This one will move here, and this one will cover the tip of the digit. So this covers the tip, this moves here, and this moves here, and you can close this V to Y. So here's the another method, which is the true Martin Evans modification of the Venkataswami Flap. And this is the defect. We elevate it with the neurovascular bundles. The nerve and the vessel are here. And the whole flap is elevated on this digital neurovascular bundle, all going all the way to the palm, but not skeletonizing the neurovascular bundle. And once you have elevated it at the level of the flexor sheath, then you can cover it. So here's that clinical case that I talked about, a volar oblique defect, an amputation of the finger. Here's the volar oblique amputation. So we take a Martin Evans flap, which is taking the longer, the bigger flaps, modification of the Venkataswami. The key is that you do a mid-lateral incision here on the dorso-volar junction, this junction of the glabrous and the non-glabrous skin, and then you'd make the flaps on the volar side, and then you advance this. See how far it's advanced. It's advanced quite a bit, and it'll cover the defect at the tip, and each of these flaps will interdigitate and close, and therefore it'll prevent the shrinking that that took place with the original Venkataswami flap. So that is the Venkataswami flap, and I'd be happy to answer any questions.
So, Amit, we do have a couple questions from the participants. One is, when would this flap, for the defect that you, kind of the example defect, when would this flap be preferred over a thenar flap? And why would you choose one over the other? Okay.
The thenar flap, there are certain disadvantages of the thenar flap. The thenar flap does not give you any sensation. And so for me, this flap is preferable because it gives an instant sensation, and the 2-point discrimination of this flap is very good. The other thing is that thenar flap requires that you keep the finger down, the PIP flex quite significantly. So a lot of patients over 40 would get flexion contractions of the PIP joint and want to avoid that. So I try to avoid the thenar flap for these 2 reasons. And if the digital neurovascular bundles are working on both sides, this flap would be preferable for me.
I see. And another question is, could this flap be modified to be raised as a smaller island type flap, or would this technique need to be kind of as described?
This technique is pretty much as described. There are other island flaps. There are homodigital, reverse homodigital advancement flap in which you rely on the Edwards arcade. You know the Edwards arcade, the communication between the two digital arteries that goes deep to the check crane ligaments of the volar plates. As long as one of them is maintained, like at the DIP joint, there is each one of these Edwards arcades are formed at the PIP, DIP, and MP joints. So as long as one of the Edwards arcade is maintained, you can take a piece of skin on the volar aspect coming proximally and elevate this. You obviously, with the reverse homodigital flap, you leave the nerve alone and you take the artery, and so it would not give you a sensate flap, but that can be done. You can choose to take the you can choose to elevate it as described, and that would be the classic one. But you have to do a digital Allen test. That's very, very important if you want to do this flap.
Right. And so do you feel, I mean, there's a couple of questions that are saying, do we need to dissect so far proximally? Is there a way of doing this with a little bit less dissection? Or do you feel, I guess, what's your opinion on that? And what do you feel about the proximal dissection?
Yeah, it all depends on the, amount of skin that you need, amount of coverage of the pulp that you require. If the amount of pulp that you require is small, then you can get away with a smaller flap and less dissection. But if you need for this flap to advance quite significantly, then I feel that, you have to do a considerable dissection, and you have to come down to almost to the palm to get that amount of advancement that you require.
Okay, great. Thank you.
Ahmed, a question I have is this flap prone to congestion? Do you need to monitor this person after surgery, or is it something where it's low risk of congestion, you can send them home?
In my experience, it's a low risk of congestion, and I've sent these people home. As once you take the tourniquet down, if the flap pinks up, I don't think you should worry about it.
Okay, thanks.
All right, well, if there are no more questions, any more questions, Kimberly?
Thank you, Matt. That's really wonderful. I appreciate your expertise and sharing your experience, and that's outstanding.
We actually have one more question if we have time.
I think we do, yeah.
Okay, is that good? Okay, what is the difference with the segmular flap, and what are the advantages of that?
Oh, there's a considerable amount of difference with the segmular flap. This flap itself has a neurovascular bundle, and also the modifications take care of the amount of shrinkage that you are expecting to get. And this is a unilateral advancement flap for oblique tissue coverage. So it's quite a unique flap. A lot of these flaps have simple modifications of each other. Over the years, you see there's all these fingertip flaps. People have described it in various little different ways. So they are all variations of it.
Okay, great. Thanks, Amit.
Thanks again, Amit. Thanks, everyone. Thanks to the faculty. If there's, we're going to close out here. I'm going to share my screen just real briefly so that everyone's aware of the upcoming educational offerings. On July 9th, we have the tendon ruptures about the wrists with the ulnar artery perforator flap, and also July 16th with tendon transfer for radial nerve palsy and how to do a good split thickness skin graft.
Oh, Marco, and I want to make a correction on that. On July 16th, the video is not, we've changed the video. It's going to be how to do an ALT flap.
Okay, thank you.
Instead of that, Mike Sincere will talk about how to do an ALT flap.
Thanks, Amit. Thanks for the clarification. And thank you all for attending, and thank you again to the faculty and the staff and everybody. And I hope you all have a great evening. Thanks again.
Thank you.